Welcome back to the deep dive. Today, we are wading into some very murky waters. We're tackling a subject that is universally human. I mean, literally everyone has felt it. And yet, from a scientific and medical perspective, it's one of the most slippery, frustrating concepts to pin down.
It really is.
We're talking about pain.
It's the great equalizer, isn't it? It connects every single person on Earth, yet, and this is the part that, drives clinicians crazy, no two people experience it the same way.
That was the biggest takeaway for me when I opened up the research for this week. I was expecting this very dry clinical overview of painkillers.
Right. Take 2 of these and call me.
Exactly. Take 2 aspirin and call me in the morning. But what I found was this massive philosophical and biological puzzle. It feels like the medical community is constantly fighting a war on 2 fronts.
Oh, that's a good way to put it.
You have the actual physical damage to the body, and then this completely invisible, subjective experience happening inside the patient's head.
That is the perfect way to frame it. And frankly, that subjective part is where the real challenge lies. The war on 2 fronts is exactly right, because you can win the physical battle, fix the bone, heal the cut, and still completely lose the war if the patient is still suffering.
Right. And our sources start with this definition of pain that it feels less like a medical diagnosis and more like a legal disclaimer.
I know the one you mean.
It defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage.
That phrase right there does a lot of heavy lifting in medicine.
It sounds like a loophole. It sounds like the medical definition is admitting, look, if you tell me it hurts, I basically have to believe you, even if I can't see why.
That's not a loophole. That is the absolute cornerstone of modern pain management.
Really?
Think about how we practice medicine normally. If you come to me and say you have high blood pressure, I don't just take your word for it.
No, you put a cuff on my arm.
I put a cuff on your arm, I get a number. If you say you have a broken femur, I shoot an X-ray. I can point to the crack.
You can see it. It's objective.
It's objective.
Yeah.
But pain, there is no painometer. There's no blood test for agony. So if a patient is sitting there, completely physically intact, no grimacing, no wounds, but they say they're at a level 10 pain.
Then clinically they are at a level 10.
Clinically they're at a 10. That's the starting point.
Which seems incredibly difficult to treat. I mean, how do you fix a problem you can't truly measure? If you can't verify it, how do you know which tool to even use from the toolkit?
Well, you have to start by understanding the machinery. You have to understand the terrain before you can build a map.
Okay.
And to do that, we have to clear up a major misconception right off the bat.
Yeah.
Most people think pain is just a switch. You get hit, the switch flips, you hurt.
Yeah, simple cause and effect.
But the literature divides pain into 2 massive, distinct buckets. And they are not just different in terms of time. They're effectively different species of the same animal.
And you're talking about the distinction between acute and chronic pain.
Precisely.
Okay, so let's break down that first bucket. Acute pain, this is what I'm familiar with. I slam my finger in a car door. It hurts like hell. It's immediate, it's loud, it's obvious.
Right. Acute pain is the body's alarm system working exactly as it's intended. It's defined by a specific injury or a noxious stimulus trauma, surgery, a burn.
There's a clear cause.
A very clear cause. The body recognizes an immediate threat and it just screams for help. And because it's an emergency response, you get very distinct, measurable physiological signs.
The body goes into fight or flight mode.
Exactly. If you come into the ER with a compound fracture, I don't even need you to speak to know you're in pain. I can see it on the monitor.
What are you looking for?
You'll have hypertension, high blood pressure, tachycardia, your heart is racing. You'll see diaphoresis, which is just the fancy medical term for sweating.
Okay.
The pupils dilate, that's called mydriasis. You might even see pallor, where the blood drains from the face to go to the muscles. The body is physically manifesting distress.
It's undeniable. You can't fake those signs.
You can't. And the good news about acute pain is that it's usually predictable. We know the cause, we treat the injury, and as the tissue heals, the pain fades.
The alarm turns off because the fire is out.
The fire's out. It follows a logical timeline.
But then we have the second bucket, chronic pain. And this was the part of the reading that really surprised me. I just assumed chronic pain was acute pain that lasted longer.
That's what most people think.
Like, if acute pain is a sprint, chronic pain is just a marathon. But you'd still be sweating and panting.
Right. That's the logical assumption.
Yeah.
But physiologically, it's wrong. And this is where patients so often get dismissed by the medical system. It's a huge problem.
How so?
Because the body adapts. It has to. You cannot stay in fight or flight mode forever. If your heart raced at 140 beats per minute for 6 months, you would go into heart failure and die.
The system would just burn out.
It would completely burn out. So in chronic pain, the body reaches this new, twisted equilibrium. Those dramatic vital sign changes, the sweating, the racing heart, they disappear.
So a patient could be in excruciating long-term pain, but their heart rate is 70 and their blood pressure is totally normal.
100%. And if a doctor is looking for tachycardia to prove a chronic pain patient is hurting,
They're going to miss it.
they are going to miss the diagnosis every single time. In chronic pain, the symptoms shift from the physical vital signs to the behavioral and psychological realm. The source material highlights things like depression, sleep disturbances, anxiety, irritability.
It stops being a signal of damage and starts becoming a lifestyle disruptor.
Exactly. It eats away at the patient's life. Social instability, family issues. The arm isn't ringing anymore. The wires have just melted into the on position.
And the sources mention a specific subset here, too. Cancer pain. Where does that fit in?
Yes. Cancer pain is often treated as its own unique category because it kind of plays by both sets of rules. It can be acute, from a tumor pressing on a nerve, or from a surgery, and it can be chronic.
So both.
It's often both, which is why it requires a much more aggressive strategy, because the cause of the pain often isn't going away. In fact, it's growing.
Okay, so before we get into how to treat these two very different animals, I want to get under the hood. Section 1 of our sources dives right into the physiology, the wiring. How do we actually feel hurt? Because it feels instant, doesn't it? But there's a whole relay race happening under the surface.
It is absolutely a relay race, and it starts with the hardware. The source distinguishes between two types of processing. The first is nociceptive pain. This is the standard wiring.
Nociceptive, that comes from noxious, right? Like bad stuff.
Correct. You have millions of tiny sensors all over your body called nociceptors. Think of them as free nerve endings. They're the scouts.
Okay.
And when they detect damage, heat, pressure, a chemical irritation, they fire. They send up the flare.
And the sources break this down even further into somatic and visceral.
Right. It's a pretty simple distinction. Somatic is the outer body. Skin, bone, joints, muscle. If you twist your ankle, that's somatic pain. It's sharp, throbbing, and usually very easy to pinpoint.
You can point a finger right at it.
You can point right at it and say, it hurts here.
In visceral.
Visceral is the internal organs, the gut, the liver, the heart. This pain is much vaguer. It's often described as cramping, squeezing, or a deep aching.
And it's harder to locate.
Much harder to localize. If your intestine hurts, you might feel it all over your belly, or sometimes you feel it in a completely different place. That's called referred pain.
Okay, so let's say I touch a hot stove. That's somatic nociceptive pain. The scout, the nociceptor fires. But the research mentions that at the site of the burn, it's not just an electrical signal. It describes a chemical soup.
Oh, it is a soup.
Yeah.
A toxic inflammatory soup. And this is really important for understanding how some of our most common painkillers work later on.
So what's in this soup?
When you damage tissue, the cells basically explode, and they release this whole cocktail of substances. The source lists them. Bradykinin, prostaglandins, histamine, interleukins, substance P.
Substance P. I love that name. It sounds like a villain in a comic book.
It essentially stands for pain. It's a key neurotransmitter for pain signals. All of these chemicals, they just hang out around the nerve ending and they sensitize it.
They make it more sensitive.
They lower the threshold. They make the nerve scream louder and easier. They are effectively yelling, hey, don't touch this area. It's damaged. It's healing.
So the nerve fires, sends the signal to the dorsal horn of the spinal cord, which seems to be the gatekeeper.
That's a great analogy. It's the first major checkpoint.
And then up to the thalamus in the brain, which acts as the relay station. And finally, the brain says, ouch.
That's the ascending pathway, the signal going up.
Yeah.
But here's where the biology gets really cool. The body isn't just a passive receiver of pain. We have a descending pathway.
So the brain talks back.
The brain talks back. It can send orders down to the spinal cord to slam the gate shut. It's our internal modulation system.
How does it do that?
The brain releases its own set of neurotransmitters, serotonin, norepinephrine, and our own endogenous opioids, to inhibit the signal that's trying to come up.
Wait, endogenous opioids? You mean our body makes its own morphine?
Essentially, yes. This is where endorphins come from. Enkephalins, gynorphins, beta endorphins. They bind to the exact same receptors that morphine does.
So a runner's high is literally the body's own opiate system kicking in.
That's a huge part of it. And the brain also uses serotonin and norepinephrine to dampen the noise. It's basically the brain saying, okay, I know we're hurt, but we have to keep moving right now, so I'm turning down the volume.
Which explains why, in the heat of battle or a high-stakes sports game, people sometimes don't even feel a broken bone until later. The descending system is just flooding the zone.
Correct, but sometimes the wiring breaks. The system itself gets damaged. And this leads us to the dark side of physiology, pathophysiologic pain.
Also known as neuropathic pain.
This is the stuff of nightmares, clinically. In nociceptive pain, the system is reporting damage. In neuropathic pain, the system is the damage.
It's not the alarm, it's the alarm company that's on fire.
Perfect. The nerves themselves, either in the periphery or the central nervous system, are malfunctioning. They're misfiring.
So this isn't my toe hurts because I stubbed it. This is my toe hurts because the wire connecting my toe to my brain is frying.
Yes. Think about diabetic neuropathy or postherpetic neuralgia from shingles, or even phantom limb pain. The source describes this as the pain circuits rewiring themselves, anatomically and chemically. They physically change to stay stuck in the on position.
And this leads to those two terms that I found really unsettling when I was reading, hyperalgesia and allodynia.
They are the hallmarks of neuropathic pain. They're what we look for. Hyperalgesia is an exaggerated response.
So a bigger pain from a painful thing.
Exactly. I poke you with a pin, and instead of feeling a small prick, it feels like a hot poker. Your volume knob is broken and stuck on max.
And allodynia.
Allodynia is even stranger. That's pain from a stimulus that shouldn't hurt at all.
Like what?
The classic example is a bed sheet. For a patient with severe neuropathic pain, the weight of a simple cotton sheet on their leg can feel like sandpaper or fire.
That is horrifying. I can't even imagine. And I assume standard painkillers like Tylenol or Advil don't even touch that kind of pain.
They absolutely don't. It's like trying to treat a software glitch with a bandage. It just doesn't work.
Which brings us to the biggest challenge, assessment. If we have these different types of pain, and it's all subjective, how does a doctor figure out what's actually going on? You can't just ask, does it hurt?
No, you have to be a detective, you have to interrogate the pain, and the source emphasizes the PQRST mnemonic. It seems simple, but it is the key to unlocking the diagnosis.
So let's walk through it. P.
P is for palliative and provocative. What makes it better? Ice, heat, lying down. And what makes it worse? Movement, eating, bright lights.
Q is for quality.
And this one is crucial. This is where the patient's own words give you the diagnosis. If a patient says aching or throbbing, I'm thinking somatic pain, maybe a bone or a muscle issue.
Okay.
But if they say burning, shooting, tingling, or electric shocks,
You're thinking neuropathic.
immediately, my brain goes straight to neuropathic pain. The adjectives tell you everything.
R is for radiation.
Does it travel? Does it start in your lower back and shoot down your leg? That's classic sciatica.
S is severity.
The famous 0 to 10 scale. How bad is it right now? What's the worst it gets? What's the average?
And T is for temporal.
Timing. Is it constant? Does it come and go? Is it worse at night? All of these little clues build the picture.
And we have to remember the context, right? The source notes that things like anxiety, depression, fatigue, anger, and fear all lower the pain threshold.
Absolutely. If you are terrified, the pain literally hurts more. Your brain is amplifying the signal because it's in a state of high alert.
So once we've assessed the patient, we think we know if it's acute or chronic, somatic or neuropathic, we have to fix it. We are opening the toolkit. And in this source material, the toolkit is divided into 3 main drawers: non-opioids, opioids, and a third one called adjuvants.
That's the standard breakdown.
Let's open that first drawer. The non-opioid analgesics. This is the first line of defense. These are the drugs we can buy at the drugstore: Tylenol, Advil, Alev. It's easy to think of them as weak drugs compared to morphine, but the source says they're actually foundational.
They are. For any mild to moderate pain, they are the absolute go-to. But they have a really important limitation known as the ceiling effect.
Which means, what is a ceiling effect?
It means that once you hit a certain dose, taking more of the drug doesn't give you any more pain relief. It just gives you more side effects. There's a hard cap on its efficacy. You can't just keep taking more and more Advil and expect it to eventually work like morphine. It won't.
Let's talk about the big group in here. NSAIDs. Non-steroidal anti-inflammatory drugs. So ibuprofen, naproxen, and stronger ones like ketorolac. How do these actually work? We talked about that chemical soup earlier.
Right. Remember the prostaglandins in that soup?
The ones that sensitize the nerve endings.
Exactly. NSAIDs work by blocking the enzyme. It's called cyclooxygenase, or KOX, that produces those prostaglandins. You're basically turning off the tap at the source.
So less prostaglandins means less inflammation and less pain signal. You're stopping the chemical reaction at the site of the injury.
Precisely. Which is why they're so good for things like bone pain or arthritis or any structural damage where inflammation is the main driver. In fact, for cancer-related bone pain, the protocol says you should almost always have an NSAI on board with whatever else you're using.
There's a catch. There's always a catch in medicine, isn't there? Prostaglandins aren't just pain chemicals. They have a day job, right?
They have a very important day job. And this is why NSAIDs have such potentially nasty side effects. Prostaglandins do two other major things. They help maintain a protective mucus coating for the stomach lining, and they help regulate blood flow to the kidneys.
Okay, I see where this is going. So when you take ibuprofen to stop the pain in your knee, you are also stripping the armor off your stomach lining and potentially choking the blood supply to your kidneys.
That's a vivid way to put it, but it's pretty accurate. That's why the biggest risk with NSAIDs is GI bleeding and ulcers. You are leaving the stomach vulnerable to its own acid.
Which is why they always say take with food.
Always take them with food. It helps buffer the effect. And for the kidneys, renal toxicity is a major concern, especially in the elderly or in people with heart failure or existing kidney problems.
The source has a specific warning about ketorolac, or Toradol. I've heard of athletes taking this to play through injuries.
It's a very potent NSAID, often given by injection, and it's frequently used in hospitals as a non-opioid alternative for, post-op pain. But the source is very, very strict on this. Maximum 5 days of use, period.
Why so short?
The risk of severe kidney failure and major GI bleeding is just too high if you go any longer. It's a great short-term drug, but a dangerous long-term one.
Okay, moving down the list in this drawer, salicylates, better known as aspirin.
Right. Aspirin is technically an NSAID, but it's kind of in its own class because it has a unique property. It also irreversibly inhibits platelet aggregation.
It thins the blood.
It thins the blood. But there is a massive, bold-faced warning here that every parent needs to know. Never, ever give aspirin to children or teenagers with viral illnesses like the flu or chickenpox.
Because of the risk of Rey syndrome?
Correct. It's a rare but potentially fatal condition that causes swelling in the liver and the brain. It's why we just generally avoid aspirin in the pediatric population for pain or fever and use acetaminophen or ibuprofen instead.
Which brings us to probably the most common drug in the world, acetaminophen. Tylenol. I think most people, myself included, kind of assume Tylenol is just brand name aspirin or another version of Advil, but it's completely different.
Completely different mechanism. Acetaminophen is an analgesic, so it kills pain, and it's an antipyretic, so it reduces fever. But it has almost zero anti-inflammatory action.
So if your knee is swollen to the size of a grapefruit, Tylenol won't help reduce the swelling much at all.
Not really. It might help with the pain, but not the inflammation itself.
So why use it over an NSAID?
Because it doesn't chew up your stomach. It works primarily in the central nervous system, so it's much safer for the gut. But it has its own unique danger zone, the liver.
And the source gets very specific about numbers here, which is a bit scary.
It should be. Acetaminophen is highly hepatotoxic in overdose.
Meaning toxic to the liver.
Very toxic to the liver. When you take it, your liver converts a small amount of it into a toxic metabolite. Normally, your liver has a substance called glutathione that immediately neutralizes it. But if you take too much, you overwhelm the system. You run out of glutathione, and that toxic metabolite just starts destroying liver cells.
So what is the limit? What's too much?
The general max daily dose for an adult is listed as 4,000 milligrams. That's 4 grams. But the text notes that some experts and even some guidelines are now suggesting capping it lower, at 3,000 milligrams, just to be safer.
And the scary part is the hidden acetaminophen.
This is where people get into trouble.
Right, because it's mixed into everything. Cold medicines, prescription painkillers.
Exactly. Drugs like Percocet or Vicodin are a combination of an opioid and acetaminophen. If a patient is taking Tylenol for a headache and then also taking Percocet for their back pain, they can accidentally hit that toxic limit very, very quickly without even realizing it.
And the source says alcohol makes it much worse.
Significantly worse. Chronic alcohol use also depletes your liver's stores of glutathione. So if you combine the two, you have much less of your natural defense, and you can get liver damage at much lower doses of acetaminophen.
So that's the first drawer. Now we open the heavy locked drawer, the opioid agents.
This is the most potent class of analgesics we have, period. Mechanistically, they work by binding to specific receptors in the central nervous system, the mu, delta, and kappa receptors.
So they hack into that descending pathway we talked about earlier.
They essentially supercharge it. They bind to those receptors, and they modulate our perception of pain.
It sounds less like fixing the problem and more like telling the brain to ignore the problem.
In a way, that's a fair description. The mu receptor is the big one. When an opioid binds there, it powerfully inhibits the transmission of pain signals. It's a very effective off switch.
And unlike NSAIDs, the source says there is no true ceiling effect for pure opioids.
That's right. Theoretically, with pure opioids like morphine, if you increase the dose, you get more pain relief. The limiting factor isn't efficacy, it's side effects. You eventually reach a dose where the side effects, specifically respiratory depression, become too dangerous to continue.
Let's meet the cast of characters. The source lists several key opioids, and morphine seems to be the celebrity of the group.
Morphine is the gold standard. It's the drug against which all other opioids are measured.
Mm.
It's versatile. You can give it IV, oral, rectal, and it has a special benefit in heart attack pain.
Oh, that's
It actually decreases myocardial oxygen demand. It reduces the preload and afterload on the heart, so it eases the workload on a struggling heart muscle.
But it has a quirky side effect regarding itching.
Yes, this is a really common point of confusion. Morphine causes histamine release from mast cells. Patients often get itchy or develop a rash, and they'll say, "I'm allergic to morphine."
But they're not.
Usually it's not a true life-threatening allergy. It's just a known side effect of the drug releasing histamine. We can often manage it with an antihistamine.
Okay. Then there's hydromorphone, better known as Dilaudid.
Think of it as a more potent version of morphine on a milligram for milligram basis. It's a very effective option, though it tends to have a shorter duration of action, which means you might have to dose it more frequently.
And then fentanyl. This one is in the news constantly, but clinically, how is it supposed to be used?
Fentanyl is highly potent. We're talking micrograms, not milligrams. The source specifically discusses the transdermal patch, and there are huge, bold warnings attached to this delivery system.
The first one being that the patch is not for acute pain.
Absolutely not. And it is a critical safety point.
Why not? If I break my leg, why can't a doctor just slap a patch on it?
Because of the pharmacokinetics. It's like a freight train. It's very hard to start and very hard to stop. When you put a fentanyl patch on, it takes 12 to 24 hours for the drug to absorb through the skin and really start working.
That's way too slow for a broken leg.
Way too slow. And then there's the other end. Fentanyl is fat soluble, so it soaks into the fatty tissue under your skin, creating a little reservoir. When you take the patch off, the drug is still leaching out of your fat into your bloodstream for another 17 hours or more.
So if you realize you've given too high a dose, taking the patch off doesn't save the patient immediately.
Not at all. The effect continues for a long time. It actually takes 6 days of continuous use to reach a steady state. You cannot use something that slow and unpredictable for acute pain. It's especially dangerous for someone who is opioid naive.
Meaning they haven't taken opioids before and haven't built up a tolerance?
Correct. Giving a patch to an opioid-naive person can be a fatal mistake.
Then there's methadone. I always associated methadone with treating addiction, but it's used for pain too.
It is, and it can be very effective, especially for chronic pain. It has a long duration of action, and it's very cheap. But it has a trap, a very dangerous trap.
And that is its half-life.
Yes. The half-life of methadone, the time it takes for half the drug to leave your body, is wildly unpredictable from person to person. The force says it can range from 8 hours to 59 hours.
Whoa, that is a massive range. How do you dose that safely?
Very, very carefully. Imagine the pain relief wears off in 8 hours, so the patient takes another pill. But the drug from the first pill is still in their system and might be for another 40 or 50 hours. They take another pill 8 hours later.
The drug just builds up.
It accumulates. And the dangerous part is that the respiratory depression effect can last much longer than the pain relief effect. So a patient can feel their pain returning and take more, while the previous doses are still accumulating and suppressing their breathing. They can unintentionally overdose days after starting the medication.
Scary stuff, if not managed by an expert. Now, there is one drug that the source seems to really dislike, meperidine, or Demerol. I'm calling this one the villain of the group.
It effectively is the villain in modern pain management. Most hospitals have removed it from their standard formularies. It's shorter acting than morphine. It's less potent.
So it's not even that good at its job.
Not really.
Yeah.
But the real problem is its metabolite, a substance called normeperidine. When your body breaks down meperidine, it creates this toxic byproduct that builds up in your system.
And what does normeperidine do?
It's a neurotoxin. It irritates the central nervous system, It causes tremors, twitching, and in high enough concentrations, it can cause seizures.
And I'm guessing that's worse in certain patients.
Much worse, especially in the elderly or people with kidney failure, because their bodies can't clear it out effectively. The expert advice in the source is crystal clear. Avoid long-term use, and absolutely never combine it with a class of antidepressants called MAOIs, because that interaction can be fatal.
So we have these powerful drugs, but they come with a heavy price tag of side effects. We mentioned the itchiness, but there are two major ones we really need to discuss: constipation and respiratory depression.
Right, and with constipation, it's the one side effect you never ever develop a tolerance to.
Really? Your body gets used to the sedation, but not the constipation.
Never. If you are on opioids for any length of time, you will be constipated. The rule of thumb in the text is a good one. The hand that writes the opioid prescription must also write the laxative prescription.
So prevention is key. You don't wait for it to happen.
You have to stay ahead of it. Fluids, fiber, and almost always a stimulant laxative.
And then respiratory depression. This is the lethal one.
This is what makes opioids dangerous. They act on the respiratory centers in the brainstem, and they slow down the body's drive to breathe. If the dose is too high, the patient's breathing rate slows, becomes shallow, and eventually they simply stop breathing.
And that's where naloxone or Narcan comes in, the reversal agent.
Naloxone is the antidote. It has a higher affinity for the opioid receptors, so it goes in, binds to them, and kicks the opioid off, instantly reversing the effect.
But there's a catch with that, too.
There is. Naloxone has a short duration of action, often much shorter than the opioid it's reversing.
So you could wake a patient up?
You might revive a patient, but 30 or 60 minutes later, the naloxone wears off, the opioid is still floating around in their system, and it reattaches to the receptors.
And they stop breathing again.
Exactly. You often need repeat doses or even a continuous infusion of naloxone while you wait for the opioid to wear off. One dose doesn't always fix the problem.
This brings us to Section 5. Adjuvant analgesics. This is the thinking outside the box drawer. Why would we use drugs that aren't technically painkillers to treat pain?
Because, as we discussed, sometimes the wiring is broken. Opioids are great for a broken leg, but they are often terrible at treating neuropathic pain. They just don't work well for it.
Okay.
Plus, we always want opioid-sparing strategies. If we can add another drug from a different class, we can often get better pain relief while using a lower, safer dose of the opioid.
So we dip into other areas of the pharmacy. First up, antidepressants.
Specifically, tricyclic antidepressants, or TCAs like amitriptyline, and a class called SNRIs like duloxetine. Remember the descending system we talked about?
Yeah.
The brain sending serotonin and norepinephrine down to the spinal cord to block pain signals?
Yes, the body's own defense system.
Well, these drugs inhibit the reuptake of serotonin and norepinephrine in the nervous system. They basically leave more of those neurotransmitters hanging around in the synapse.
So they're boosting that natural descending defense system.
They're supercharging it. And they are incredibly effective for neuropathic pain, fibromyalgia, and chronic headaches.
Then anticonvulsants. Seizure drugs. How do they help with pain?
Drugs like gabapentin and pregabalin. Think about it. Seizures are caused by nerves in the brain firing uncontrollably. Neuropathic pain is caused by nerves in the body firing uncontrollably.
It's the same basic problem.
It's a similar problem of membrane instability. These drugs work by stabilizing the nerve membranes to stop the misfiring. They are the absolute first line of defense for that shooting, shock-like neuropathic pain.
And finally, in this drawer, local anesthetics.
Right. This could be as simple as a lidocaine patch that you put on the skin for localized pain like with shingles. Or it could be more invasive, like epidurals and nerve blocks using drugs like bupivacaine.
And these physically block the signal.
They physically block the sodium channels in the nerve so the electrical signal can't get through.
Yep.
But you have to be careful. If that local anesthetic gets absorbed into the bloodstream in large amounts, it can be toxic to the heart and the brain, causing heart block or seizures.
Okay, so we have the tools. Now, how do we build the house? Section 6 is all about strategy and monitoring. There's an algorithm mentioned, the analgesic ladder.
It's the classic approach often attributed to the World Health Organization. It gives you a simple stepwise strategy.
So walk me through it.
For mild pain, 1 to 4 out of 10, you start with a non-opioid, acetaminophen or an NSAID.
Tip 1.
Step 1. If the pain is moderate, say a 5 to 7 out of 10, or if step 1 fails, you move to step 2, a combination. You use a weak opioid plus a non-opioid. something like codeine with acetaminophen.
And for severe pain?
For severe pain, an 8 to 10 out of 10, you go to step 3. Potent opioids like morphine or hydromorphone, often still with a non-opioid on board.
And again, there's that note about cancer pain. If bone pain is present, an NSAID should always be part of the mix no matter what step you're on.
Always. It attacks the underlying mechanism of bone pain prostaglandin release from the tumor directly. It's a vital component.
But when we shift from acute pain to chronic pain management, the goalposts move, don't they? We aren't really trying to cure the pain anymore, are we?
No, not usually. In chronic pain, the focus has to shift from cure to function. If we try to drive the pain score to 0, we might just sedate the patient into a coma with side effects.
So what are the goals?
The goals become, can we minimize the pain to a tolerable level? Can we maximize the patient's functioning? Can they go to work? Can they sleep through the night? Can they engage with their family? It's about improving their overall quality of life.
And to keep track of this, the source lists the 4 A's of monitoring.
This is a great, simple framework for any clinician treating chronic pain. It keeps you focused on what matters.
So what are they?
The first A is analgesia. Pretty simple. Is the pain better? Is the treatment working? The second A is activity. Can you move better? Can you function better? Are you meeting your functional goals?
Okay.
The third A is aberrant drug behavior. Are there early signs of addiction or misuse? Are they losing their pills, requesting early refills, getting prescriptions from multiple doctors?
And the fourth?
Adverse effects. Are the side effects, like constipation, nausea, or sedation, manageable? Or are they worse than the pain itself?
You mentioned aberrant drug behavior. This leads to a very, very important distinction the text makes between tolerance, physical dependence, and addiction. Because I think people, and maybe even some doctors, conflate these 3 things all the time.
They do, and it causes a huge amount of problems in patient care and a lot of stigma. They are not the same thing.
Let's define them. Tolerance.
Tolerance is purely physiological. It just means that over time, your body adapts, and you need more of the drug to get the same effect. It's a normal response.
Physical dependence?
Also physiological. It means your body has gotten used to the presence of the drug, and if you stop it abruptly, you will experience withdrawal symptoms. Again, this is a normal, predictable pharmacological effect. Neither of those is addiction.
So what is addiction?
Addiction is psychological and behavioral. The source defines it by characteristics like impaired control over drug use, compulsive use, craving, and continued use despite demonstrable harm. It's a brain disease. It's a very different beast from a body simply getting used to a medication.
There's also a fascinating term here called pseudo-addiction. That sounds fake.
It's actually very real and very tragic. Pseudo-addiction is when a patient exhibits behaviors that look like addiction. They're clock watching. They're asking for drugs aggressively. They're complaining about their doses.
See, they're acting like an addict.
They are, but it's because their pain is being undertreated. They're desperate for relief. And the key is, if you actually increase their dose and get their pain under control, all of that seeking behavior stops. They weren't addicted. They were just in pain.
That is a crucial distinction. It really highlights why that initial thorough assessment part is just so important.
It's everything. You have to get the diagnosis right.
So let's synthesize all of this. We've gone from the nerve-ending screaming fire to the dorsal horn, up to the brain. We've looked at the chemical soup at the injury site, the rewiring of nerves in chronic pain, and this massive pharmacological toolkit, NSAIDs for the soup, opioids for the receptors in the brain, antidepressants for the descending pathways.
It really reinforces the modern idea of multimodal analgesia. You don't just hit one button. You attack the pain from different angles simultaneously.
It's a combined arms assault.
Exactly. Use an NSAID to stop the inflammation at the source, an opioid to dampen the signal in the brain, and maybe an anticonvulsant to calm the misfiring nerve itself.
Yeah.
That is how you get effective relief with lower doses and fewer side effects.
It's like a symphony of pain management, not just a single instrument.
That's a great way to think about it.
Before we wrap up, I want to leave our listeners with a thought that came to me while reading about that rewiring of the nervous system in chronic pain.
What is that?
Well, if the pain system can physically change its structure to become better at feeling pain, which is what chronic pain essentially is, what does that imply about the future of treatment? If the body can wire itself into a state of pain, can we learn how to unwire it?
Neuroplasticity.
Are we looking at a future where we don't just mask the pain, but we can actually reverse the structural changes in the nervous system that cause it?
That is the holy grail of pain research. Neuroplasticity works both ways. If we can map exactly how that bad road was built, then theoretically we can figure out how to tear it up and build a new one.
Something to think about. Thank you for diving deep with us today.
Always a pleasure.
And to our listeners, next time someone tells you they are in pain, just remember, it's subjective, it's complex, and their body might be telling a story that no X-ray or blood test can ever show. Respect the pain. We'll see you on the next deep dive.